shoulder arthroplasty in the last 20, 30 years has really taken off. And you'll hear about the changes in the thought processes that has gone on. When we were training, it was very simple. You either did a hemi or a total, and there wasn't really much difference between the designs, but things have changed quite a bit. And we have an understanding now with time about the failures in each of the groups, and some alternative options are now being put forward, but we still don't have some long-term results. So what I decided is there's a problem group, is the young arthritic patient, and then the decision-making about anatomic and total shoulder replacement. So by the end of today, the learning objectives are essentially to have an understanding about the options that are available for you for failed conservative treatment for shoulder arthritis, and some of the problems and how they're being addressed by the distant shoulder groups around the world. And I will talk at the end on, I had to give a talk at a global arthroplasty meeting that was put around the world. I had to put a talk together, so I've got a couple of different options which we'll see and highlight the treatment probably for the younger patient, which Kim's going to start us off with, is the young patient with arthritis. And the reason it's such an interest for us is because there are a different group of patients. And if you're young, that's under the age of 60 with arthritis, you have 4 times as many complications as an older patient who has a shoulder replacement. So that's one of the biggest reasons that this group is different and being looked at, and the different options that have been explored. So maybe Kim, you can start now.
Okay, Prof. So I'm just doing a quick background on the young glenohumeral osteoarthritis. And as Prof said, it's considered patients less than 60, although we know some of our patients are physiologically younger than their age. So any active patient could be considered a young OA. I don't know why it's not going on next. There you go. So I just wanted to quickly highlight that this is not exactly the same as normal primary osteoarthritis. There are so many other things to take into consideration and so many other etiologies that can result in young OA. And it's important to identify these and treat them according to their merits, especially like I highlighted here, the osteo or AVN and glenoid dysplasias, because those warrant slightly different management. I'm not discussing the conservative options, so just the surgical options, and those include glenohumeral debridement, like removing loose bodies and cleaning up the shoulder. Then Prof's going to discuss with us the CAM procedure or millet procedure, which is a shoulder joint preserving technique. Then the next option is resurfacing, and that can either be done arthroscopic or open. And then there's hemi-arthroplasty with or without a few added extras. So either a glenoid resurfacing, which is biological, or an interposition, or a ream and run, where the glenoid is just reamed and left. Then there's total shoulder arthroplasty and the reverse. And the last resort would be then arthrodesis or resection arthroplasty, which we try to avoid in young patients. So this is the article that I'm discussing. It's from 2022. So this year it's fresh, and it's just a systematic review on outcomes related to the different surgical options for these young patients under 60. It's just highlights as well that there's still a lot that we don't know, and that there's a lot for us to still investigate. So it's a systematic review of, they included 34 eligible studies, a total of 1,535 shoulders with a mean age of 47.6. However, you can see that it's very difficult to interpret because there was a wide discrepancy in ages used, and some studies that they included even seemed to have some outliers in terms of age. And then It's important to highlight the key differences between an older patient with OA receiving arthroplasty versus a young patient. So even though the young patients only represent about 5 to 10% of shoulder arthroplasty, they are in their working prime with higher activity levels, and they need a greater durability of their reconstruction. They also have greater functional expectations, and it's important to manage those. And they present with more complex types of arthritis, like I described in the beginning. So they highlight there that the focus is on implant longevity and how many or what the need for revision is. So looking at hemiarthroplasty, that showed less pain relief and functional improvement than total shoulder arthroplasty. And the concern is of the posterior glenoid wear. So they highlight that this should only be used in patients with a concentric glenoid, so not in a patient that has a dysplastic glenoid. And then obviously early OA or failure of that glenoid. And they have the highest rate of complications out of the options that we'll discuss, so 21.7, compared to reverse, which had 19.4, which was statistically significant in this systematic review. But they had a better external rotation post-operative compared to the reverse. So then there's hemiarthroplasty with glenoid biological resurfacing. The problem here is that there are multiple different methods that were used. However, all of them essentially showed less improvement in terms of outcome scores and a higher rate of associated complications. And these patients had the highest rate of revisions as well, and completely unacceptable level of 34.5. And their outcomes were the most unreliable. In terms of total shoulder arthroplasty, the modern total shoulder with cemented polyethylene glenoid components is what they mostly looked at. You'll see they excluded the metal back glenoid prosthesis. They called them outliers because the complication rate was 91.3% in the young patients. So they excluded them. If they excluded those patients, then the total shoulder actually had the lowest complication rate of all the options. They had a better pain score and range of motion improvements compared to preoperatively. And they had the concern for the total shoulder is obviously the glenoid component loosening over time. Then the reversed total shoulder was initially reserved for elderly patients. However, it's been used more commonly now with young patients with these specific indications. So severe fracture patterns, critical cuff deficiency or irreparable cuffs, and severe glenoid bone erosions, and often used for a previously failed arthroplasty cases. So it's found in this study to be a reliable in terms of clinical improvements. It had the highest improvement in abduction, but the worst in terms of external rotation. And the low midterm rate of complications was 19.4, which is, I think, almost exactly the same as the total shoulder. And the revision rate was 13. Of note is that they highlighted that they need further studies to evaluate. They don't have enough data to talk about the long-term complications. They only refer to their midterm outcomes. And that's all for what I got from that study. I know Prof is going to discuss the CAM Miller procedure.
Okay, thanks very much, Kim. So if we look at this group, I think Ashley's going to show some of the other options that are available in the design of the shoulder replacements and their outcomes. If you look at the Australian registry for the young male who have the highest complication, is they're putting a pyrocarbon head, which is essentially a much softer prosthesis than the metallic heads. And they seem to have less revisions than an anatomical shoulder replacement, or a resurfacing, or stemmed or stemless prostheses. That is out of the Australian registry. Out of the other registries, it's a bit difficult to tell because so many people are doing it and they have different surgeons, and it's really difficult to tell. But there really is a big problem with the younger patient and shoulder replacements, and it's all on the basis of the glenoid. The glenoid comes loose. So we've actually got at the biomechanics lab a new glenoid design which is being tested. We've set up a testing jig which has not been which is a new type of jig. It's not been used anywhere else in the world as yet. Some components have, but not a complete component. So it's going to allow us to maybe redesign the glenoid, which comes loose. That's the major problem in the young patient. In a study in the rheumatoid arthritis, at 10 years, 80% of the glenoid had signs of loosening in the rheumatoid population. Luckily, the majority of them didn't seem to have too much pain or problems from those glenoid loosening, but that's a particular group of patients, is the rheumatoid patient. So I think before we discuss anything further about the young patient, we can carry on with Ashley, who's going to be talking about anatomical shoulder replacements, and then Yapi is going to talk about reverse shoulder replacements. And if there are any questions now, does anybody want to ask any questions? Okay, so no questions. Off you go, Ashley.
Hi, everyone. Can you see my screen?
Yes, we can.
Okay. Sorry, I just need to check. Yeah, so I'll be just talking about this is basically a short summary on some pertinent topics in anatomical shoulder replacements. So indications for anatomical shoulder replacements are advanced glenohumeral arthritis with significant pain, disability impeding activities of daily living, with glenoid chondral wear to bone. Sort of relative indication is age over 65, because as Prof mentioned, below 65, they have about 4 times the complication rate. In terms of outcomes, anatomical shoulder replacements for the appropriate patient provides pain relief, improved function, and lower revision rates, especially compared to hemi-arthroplasty. So a standard anatomical total shoulder replacement in terms of longevity measured by revision rate is about 90% at 10 years and 80% at 20 years. So quite good outcomes in general. But there are some motion restrictions for patients post anatomical shoulder replacement. There's no clear exact evidence on the exact motion restrictions. In general, these restrictions are set by each surgeon, and there is some variability among different surgeons. But in general, patients are cautioned or prohibited from overhead sports, weight training, or heavy work. Typical guidelines say no repetitive overhead sports, except for recreational swimming, no lifting over 20 pounds, but golf, jogging, hiking, and those kinds of activities are allowed. So because of these activity restrictions, the ream and round procedure has come into the fold. So one can look at this. This is a typical components for an anatomical total shoulder replacement. You've got the humeral component and the glenoid component. So for ream and run, this is for patients who are very active, who want to continue activities that are typically restricted with an anatomical total shoulder replacement. And so what happens in ream and run is that the arthritic humeral part of the joint is replaced, but the glenoid, but there is no glenoid component because the reason, a main reason for the activity modification in anatomical shoulder replacements is the highly likelihood of glenoid failure. So here you don't have a glenoid component. The bone of the arthritic glenoid is reamed to the desired shape, and the raw bone surface is allowed to heal while the patient goes through rehab and physio. And during this recovery, a sort of a smooth fibrocartilage surface forms over that reamed part of the glenoid. The disadvantages of ream and run are that it's a more painful recovery. It's a much more complex and intensive post-op rehab situation, and they take a longer time to recover than a normal anatomical shoulder replacement, about double the time in terms of recovery. In terms of rotator cuff and the anatomical shoulder replacement, rotator cuff function is integral. And so rotator cuff deficiency or fatty atrophy is a contraindication for an anatomical total shoulder replacement. Anatomical total shoulder replacement can be considered for people with repairable cuff tears. And in terms of surgical techniques involving the rotator cuff, especially to mobilize subscapularis, there are different techniques used, such as a lesser tuberosity osteotomy or subscapularis peel, where it's just peeled off the humerus. And they found no real difference in terms of recovery and long-term outcome between these two techniques for subscapularis. In terms of bony defects of the glenoid and anatomical shoulder replacements, it's very important to adequately correct glenoid retroversion because glenoid retroversion results in increased osteolysis, pain, and glenoid loosening. So there are various methods to correct this glenoid bone deformities. The one that you can see here is what we call eccentric reaming, where there's a glenoid defect and one reams eccentrically to correct that defect. Other methods are bone graft, augments, but for severe deformities of the glenoid, one would have to use reverse total shoulder arthroplasty. Glenoid bone loss up to the coracoid, so severe glenoid bone loss is also a contraindication for an anatomical shoulder replacement. In terms of glenoid design, there are various designs. There's keeled designs. That's the design that you can see on the right, and peg designs, that's the design on the left. So keeled components generally have higher rates of lucency. About 46% have lucency at 2 years versus pegged components, which only have 15% of lucency. So this is related to, basically lucency relates to higher rates of ultimate loosening. And also polyethylene glenoid components are preferred compared to, so all poly components are preferred for the glenoid compared to metal back components, because metal back components have higher failure rates. So there are various complications for reverse total arthroplasty, often similar to other joint arthroplasty, but the most common complication is glenoid loosening. About 30% of complications are glenoid loosening, also subscapularis repair failure and stiffness. Infection is relatively uncommon. There are different articles, but around about 1% infection rate over the first 10 years. And what's topical about shoulder replacements is that there's a bacteria called Cutibacterium acnes, which is strongly associated with PJI in shoulders. So the most common bacteria for PJI in shoulders is still Staph aureus, but a close second is Cutibacterium acnes, because this bacteria is prevalent in the shoulder area. And this commonly causes indolent infections, which have low yield on micro samples, and thus need prolonged cultures. And sometimes you have to send specimens for PCR studies, such as 16S rRNA. So thank you, everyone. That's sort of my brief summary on anatomical total shoulder arthroplasty.
Thanks, Ashley. Yapi, do you want to give your talk and then we can talk about it?
Yes, Prof, I can do.
Okay.
Prof, hi, Prof. Can I ask you a question, please?
Yes.
Just in regards the glenoid component, Ashley, as you mentioned, they said like there's a poly and there's a metal pack, and he mentioned that the poly is better than the metal packet. So I'm not sure. I thought the metal pack is much better because as in regards the literature, they said it has very good results. And the advantage is it doesn't rely on the cement fixation, and it allows like a bony ingrowth. But for the poly, you need a cement. I'm not sure. So which one is better?
Sorry, some of that broke up there a little bit. You're saying that some people are using metal glenoids.
Yeah, so I thought the metal pack is much better than the glenoid because it doesn't rely on the cement fixation.
Yeah, the metal blacks have been shown to fail in many studies now. To use a metal back glenoid is not an ideal option. You get a good fixation, you can use it with bone graft, but the problem is they get polyethylene wear and uncoupling of the polyethylene of the glenoid. And so there are some people still using it, and there's 1 or 2 reports that have reasonable results. But if you look at the failures and revision rates, and the one was quoted there by Kim, was a 90% revision rate. So people are not using metal back glenoid. There's now hybrids where there's some titanium meshes on the back of the pegs and other options that are being used, but they all have short-term results. But most of us shy away from a metal back glenoid. In fact, I don't think there is a metal backed anatomical shoulder replacement in South Africa, but I could be wrong. Nobody's shown us, but we've seen the hybrids with the metal pegs. So at the moment, is not the solution. And maybe in the future, because we can see the glenoid does not fail in the reverse shoulders unless you technically put it in the wrong way, which Yapi will probably talk about now. So at the moment, metal back is not the way for anatomical shoulder replacements. There is an advantage to them, is that if you have a metal back glenoid that you can change to a reverse shoulder if you have a failed anatomical because of rotator cuff tears, because that's what happens with time as you age. The rotator cuff may fail, and that's one of the reasons for revisions. And I've seen 2 this year that are one at about 6 years and another one at about 7 or 8 years, one of mine and one of somebody else's. And then you have to go to reverse. And if you have to take out the polyethylene, you've got a big defect. But if you've got a metal back glenoid that you can change to a reverse, and it's an ideal option. But we don't tend to use the metal back glenoids. It might be an option in an older patient where you think they've got 5-10 years. But then most people are just going to a reverse shoulder. But I think Yapi is going to mention that now.
Okay, thanks.
All right, Prof, can you see?
Yeah, we can see.
All right, so let's just go to... All right. So yeah, my talk tonight is on the reverse total shoulder replacement. I think benefit for the guys writing and for the guys writing soon is not to know all the intrinsic detail about how the designs and the stemless, non-stemless, cemented, non-cemented stuff, but actually what is the reverse total shoulder designed for and how it is designed to work, and sort of a little bit about the biomechanics around it and the indications. And again, I'll be highlighting the use of a reverse total shoulder replacement in the young patient. So just starting off with the introduction. So the reverse shoulder was developed in the 1980s as for the indication of rotator cuff tear, which developed arthropathy in the elderly patient. The new National Joint Registries shows a 10-year survivorship of rotator cuff arthropathy of 94.1% if he or that patient had a rotator cuff tear with arthropathy and a reverse total shoulder done for that. And it didn't take long for this single indication to expand into the primary osteoarthritis group with loss of rotator cuff function, which we've mentioned now, or Ashley just mentioned as one of the complications of your anatomical shoulder replacements. The Australian National Joint Registry, which Prof mentioned with the pyrocarbon replacements, they've recently, over the 10 years, reported an increase of 42.2% of joints being done. In 2009, they were reverse total shoulders, and in 2018, 77.9% of Australia were doing reverse total shoulder replacements alone. So just looking at your prosthesis design, so you get a 155 degrees and you get a 135 degrees. So I'll focus first on a 155. That's the original Grammont design, which was firstly designed in 1980. The design was 115 degrees. So if you look there, that is sort of it's a more horizontal inclination on your neck shaft angle. So it's 155 more horizontal. So what that essentially offered the surgeon and the patient was your center of rotation moved medially and inferiorly. So you get increase in your deltoid fibers availability for abduction and forward flexion. Also, you get increased deltoid, your deltoid efficiency by elongating the deltoid, essentially elongating your lever arm. But unfortunately, it weakened the teres minor and your posterior deltoid, which lead to decreased external rotation. Just looking at the design for the 135, this is the newer type of design. So essentially, if you put in a 135, and this is the type of design we prefer in our unit, not the 135, we use the Turnier, which is a 145, but the 135, surely the new kid on the block. So it essentially lateralizes the center of rotation instead of medializing it. It's a less stable one compared to the 155, but significantly less notching. With this, you can get increased external rotation. And according to some studies, or the newer studies, they say there's no difference in forward flexion. So it's just if you guys, this is just a nice summary or in a table form, which I just mentioned now. The biggest problem with your 155, the older or the Grammont, was you notching. You've got increased notching, leading to increased micromotion at the base plate, and which leads to implant failure at the glenoid. There's also increased shear forces at the glenoid. The 135 addresses these problems, but that doesn't say that there's not notching anymore. There is still notching, but that is also it depends on your technique and how you place and what inclination you place the glenoid compared to that of the humeral side, which I'll talk about on a bit later. But whenever you get asked in an exam, I'm sure this is not going to be a long question, but some clever professor might put this in the exam, asking the difference between a 135, 155, and it's essentially notching stability and range of motion. This is just a quick summary of what I just mentioned. So for the glenoid, we're looking for lateral offset. So that would decrease scapular notching, increase range of motion, and improve soft tissue tensioning. We, in our unit, we aim for placing of the glenoid with about a 3.5 inferior rim to place the, or how can I say, your glenosphere, 3.5 centimeter of overhang, also to counter that scapular notching effect. We aim for a 5 to 10 degree of inferior inclination, which has been proven to for longer survivorship of your implant, especially on the glenoid side. And same with hips, larger diameter, 40 or 42, improved range of motion and may increase your stability. Then again, various neck shaft angle, 135, 145 neck inclination may result in an increased range of motion, decreased scapular notching. Coming on to the indications. So like I've said in the previous one, so you do use this for osteoarthritis with cuff arthropathy. Then we can add these ones to the list. Your massive irreparable rotator cuff tears with or without osteoarthritis. Those are the ones you cannot repair, or you cannot repair it to a point where you can you can medialize it more than 7 millimeters. You can't get it repaired. There's no partial repair or options for it. There's no patches. No. If you run out of options, your reverse total shoulder still remains your bailout for a massive irreparable tear. Osteoarthritis, we're looking at a posterior glenoid wear of more than 16 degrees and posterior subluxation of 80. Some of the literature does they do quite a 60 to 80, but I mean, between Prof Roche also would say we use about around an 80 cutoff, 80% posterior subluxation. Rheumatoid arthritis, you get the medial glenoid wear, fractures, your 3 and 4 parts, which is not reconstructible. That is for the younger and the older patients. Then there's an increased trend to use your reverse total shoulder replacements in revisions. That is for your anatomical, for your hemis and your failed fracture fixations, and also now then making its debut in tumor surgery. But the question still remains, what do you do with a younger patient less than 65? The general feeling is, well, definitely in our unit, but in most units in the world, that is that the younger patient with the reverse total shoulder doesn't do as well as the older 65 plus 70, 75 year olds. For them, you would almost deplete all other options like a CAM procedure or a hemi if it's indicated. But for the young patient younger than 65, it still remains a problem, and I'll go into further discussion about it now. Just going into a few more literature on these indications. So traditionally, your posterior glenoid wear has been managed with either anatomical, total shoulder, and asymmetric reaming like Ashley just showed, and with the use and plus minus bone, your posterior bone graft, the posterior augmented glenoid. These were especially true for your glenoid bone loss, which according to Walsh's classification was your biconcave, your biconcave by two, your B2s, B3s, and Cs, which are your dysplastic ones. But Walsh himself in 2012 published in the Journal of Shoulder and Elbow Surgery on 92 patients with a mean follow-up of 77 months, looking at your anatomical shoulder replacements with a biconcave glenoid, which is a B2, with primary osteoarthritis, and they found glenoid loosening 20.6% and a revision rate of 16.3 for these patients, or this in this patient cohort. Again, going on your anatomical shoulder in the setting of a posterior glenoid deficiency. So why does it fail? So you get, instead of your reverse or your reverse, which gives you that semi-constraint of your head, you get recurrence of femoral head subluxation, you get early polywear, and you get your glenoid component failure, whether it be the rocking horse or whatever has been described. So the reverse addresses this problem with its semi-constrained design, corrects the posterior head subluxation. For fractures, your 3 and 4 part proximal humeral fractures in elderly patients. So a number of recent studies have demonstrated improved clinical outcomes with reverse total shoulder arthroplasty compared to hemiarthroplasty. Where possible in the younger patient, you should rather aim for surgical fixation rather than an arthroplasty option. Lopez et al. Recently randomized trial in 2019 also published Journal Shoulder and Elbow. They compared your non-operative treatment versus your reverse total. They had 59 patients in the cohort, aged all 80 years above, and do mention that these are very low demand patients with multiple comorbidities. They all had 3 and 4 proximal part humeral fractures, and they found that there were no difference in clinical outcomes at 12 months if you treat these patients with either a reverse or with non-surgical management. And they do quote that most surgeons would only operate on a patient aged over 80 years if they were high functioning with an elevated quality of life. But looking at your fracture patterns, the undesirable sequelae such as your malunion, your non-union, your avascular necrosis, your chronic lock dislocations, whether this be younger or older patients, your reverse total shoulder is a good option for younger patients who present with one of these problems. I mean, if your hand are forced, then your reverse still is a good option in these patients, but you must be cognizant of the fact that you've got a higher complication rate, and those are particularly dislocations in this patient group. Regarding your revisions as an indication, most common reason for revisions are your anatomicals that's got a cuff failure, as previously mentioned. The second one is for instability following your total shoulder replacement. Whether you, when you revise your anatomical to a reverse, they have decreased pain, they've got increased function outcome scores, increased range of motion with a complication rate of 18%. Your anatomical shoulders, the other one which you do revise them to a reverse is for aseptic glenoid loosening or failure of the glenoid component. Here your complication rates are a bit higher, that's about 30%. Like Prof said, if you have to take out a big poly that you used on your anatomic, you might find that there's a significant or not so insignificant or significant bone loss with cement still in the holes and everything. So it makes it a little bit more difficult. Your complication rates do go up, and especially with the use of a bone graft and your non-modular systems. By non-modular systems, I mean, like Prof said, if someone can develop a metal back poly or a metal back glenoid prosthesis, which you can just convert to a reverse, then you wouldn't have as much of a problem. Whereas on your humeral side, we see nowadays that you can convert from a hemi to a reverse, which makes your modular systems more attractive options. Tumor surgery, especially in the treatment of sarcomas, neoplasmas, especially if there's resection of the tuberosities and rotator cuff in order to obtain clear margins. The reverse is now an option for reconstruction that has demonstrated satisfactory functional outcomes, but do note that these patients also have a complication rate of 30% in recent literature and reviews. With this, you can be sure to be restoring of satisfactory shoulder function, cognition of high complication rates. Always consider your extent of bone and soft tissue resection, and before embarking on putting in a reverse in a tumor patient, just be aware of what the patient functionality and life expectancy is. Then we're getting to the reverse total shoulder in the young patients. Surgeons have been, for many years, been reluctant to perform a reverse in a young patient. They were worried about the implant and how long it's going to last. And your clinical results seem to have started to deteriorate after 6 to 10 years, with high rates of complications such as loosening, instability, and sepsis. But the Australian National Joint Registry, again, in 2019, reports significant increase in revision rates at 7 years if you put in a reverse in a patient younger than 65. If you look at this, if you're over than 75%, you've got a complication or revision rate of 2.7, whereas you between 55 and 64, which underline that you've got an almost double increase to have your joint revised with a 5.7%. You've got high rates of revision in younger patients. Unfortunately, this is also, maybe fortunately not only limited to shoulders, but whether it be an anatomical reverse, a hip or a knee in a very young patient, I think the general feeling is that they won't do as well as the older patient. So Wagner published in the journal Shoulder Elbow Journal 2017 they looked at almost 5,500 consecutive shoulder replacements, whether it be anatomical, reverses, or hemis, between 1970 and 2012. And they noted a 3% decrease in risk for revision surgery with every 1 year increase in age. So meaning if your risk of having a revision, the older you get, with every year, it decreases by 3%. Goldberg, on the other side, on a recent meta-analysis, said the reverse is safe and effective in patients younger than 65. Complication, reoperation, and revision rates similar to your older population cohorts, with significant improvement in clinical outcome scores. That would be with a mean follow-up of 4.7 years. So when you say that old thinking of old school of thinking of patients not doing well, there might be a turnaround if you read Goldberg's recent article. Just touching on two controversies, which is probably not controversies, but complications of reverse total shoulder replacements, which I have not mentioned, is that of the acromion fracture. So on the left-hand side, you can see reverse shoulder, the reverse being done, but just superior to that glenosphere, you can see there's an acromion fracture, and then some nice new hardware placed to repair the acromion. So with acromion fractures or with reverse total shoulder replacements, once you start to lateralize or medialize and inferiorize, just remember that you're putting tension on your deltoid, and that is the main driving force for a reverse total shoulder. So if you hear Prof in theater tell you or show you the auxiliary nerve in every reverse patient or every case we do, then you start to realize that if you damage the auxiliary nerve, your deltoid won't work, and that is your driving force for this prosthesis you're busy putting in. So considering the deltoid, so if you increase your lever arm by medializing or distalizing or inferializing it, you do put tension on it, and there might be an increase in strain on your acromion as well as your spine or the scapula itself, and that may lead to fractures like we've seen here. So King et al. In a systemic review of 90 articles, he said the incidence of acromial and or scapular spine fractures tend to be 2.8%. Problem is you get decreased forward flexion. Most patients only get up to 95 with abduction of 76%. And they noted that it has a marked detrimental effect on outcomes following your reverse total shoulder arthroplasty. The other controversy would be your subscap, and that is you can't do an anatomical shoulder replacement if you don't have an intact subscap. With a reverse, we do a subscap peel with or without a repair, depending on the amount of external rotation limitation the patient will have post-op. But recent studies show no difference between repair and non-repair groups. Your modern lateralizing prosthesis led to decrease in stability compared to your classic Remond, which increases your joint reaction forces and your wrapping angle of the deltoid muscle, which says that your newer prostheses are more stable than the original classic Remond was at that stage. And they're not so sure if you should repair subscapularis or not, and also does it really contribute to your stability of your shoulder post-operatively. So the recommendation was for your non-lateralizing fracture prosthesis, the recommendation is to repair your subscap and to fix your lesser tuberosity if there was a fracture. In elective reverses, your subscap repair is recommended, but also depends on your tendon and muscle quality and your restriction of external rotation. And that is all from me.
Thanks very much, Yapi. This hour doesn't give us enough to really go through everything about total shoulders and anatomical shoulders and reverse shoulder replacements. But as we can see, the reverse shoulder replacements are taken off, with about 75% of shoulder replacements being put in now, compared to none or less than 10% 20 years ago. I mean, the indications have spread, and now it used to be reserved for 75-year-old women with massive rotator cuff tears, and now it's being done in younger and younger patients. And for the young arthritic patients, very often they have posterior glenoid wear, as we heard from Kim. A large number of them have either posterior instability or a B2 or B1 glenoid, which actually makes the failure rate for the anatomics higher. So now people are starting putting it in the younger patient with some good results. I have a young guy, 40-odd, that we eventually put it in because he had a failed tendon. He had a failed subscapularis following an anatomical shoulder replacement, which he had for sepsis following multiple operations for instability. He managed to fracture the stem 6 weeks after falling down the stairs, and I saw him last year and sent him on to Basel to do his other side, but he's more than 3 years now with the reverse on the right, and he's kite surfing, skiing behind boats with the reverse shoulder. So the exception always proves the rule that maybe it is good in young patients. I'm not sure. We've had published a paper saying that the deltoid gets fatigued with time because you increase the length and force that is required by the deltoid for your function. Now, other papers are trying to disprove that, but Jonathan Glenday published on the really more the theoretical study of the failure of the results over time because of fatigue of the deltoid muscle. But now people are keeping the supraspinatus on, so you've got an additional muscle and tendon unit decreasing the forces on the deltoid. So things have changed. It's a rapidly evolving part of shoulder surgery, is the design of the reverse shoulder replacement. So if we go back quickly to the anatomical shoulder replacement, the biggest problem with the anatomic is the glenoid. And there have been some design changes, like we heard about the metal back, which are not doing well, then hybrid ones with sort of metal embedded pegs or keels. But there's no solution. We haven't come up with a solution, and I'll talk about a couple other options. And then the humerus is not a problem in the anatomic, but yet in the anatomic, we're putting and resurfacing implants, stemless implants, short stem implants, and that's the lowest complication rate is actually the humeral side in the anatomic. And yet on the reverse side, our most complications are actually on the humeral side. So they have also been changing the humeral design into, you can get a stemless implant and a short stem, but some of them have had problems with lysis around these implants, and we certainly don't have long-term studies. Ben Gray published in 2019 on the problems of a systematic review on humeral loosening in reverse shoulders, and showed there were only 2 papers with more than 10 years follow-up. So we don't have long-term follow-up on these patients, so we don't know what's going to happen over time to the humerus. The glenoid seems to be fine in reverse, and it's the opposite way around in the anatomical shoulder replacement. Right, are there any questions? When I'm going to show you a short, a more visual type of presentation on a couple of cases that I would present. Really, it's for the younger patient, and what are your options and some outcomes that from the literature. Anybody want to make any comments or say anything? Can you see my slide?
Yes, Prof.
Okay. Any comments or questions? Okay, so this paper that was published, I learned from, I was at a meeting in Wrightington when Peter Millett was there, and he showed me his early results of his CAM procedures, which were pretty impressive. So I started doing them. We used to do a couple of debridements a long time ago, but the CAM procedure, which we always forget about it, I think it's a comprehensive arthroscopic management of osteoarthritis. And he followed up his patient for 10 years and had some dramatic results that have stood the test of time. but he did identify the worst group in the patient with B2 glenoids. And if you remember, this is usually the younger patient who are getting a problem. If you're over the age of 50 and more advanced osteoarthritis, my experience has been so far it's the older patient. If you're over 60, nearly all my revisions have been over 60, except one I will show you just now. And obviously the patient with more advanced OA probably don't do as well. So it's really reserved for the younger patients who refuse an arthroplasty and understand the failures of the CAM procedure. And there's no doubt, even now at the age of 60, I would probably go with a CAM procedure if I had early osteoarthritis than a shoulder replacement. Because if you have a sepsis or a chromial fracture or one of the other complications, you'll be far worse off than a simple CAM procedure, which may give you some good results. So, for example, I'm just going to show you a couple of cases that we did over the years and had presented this meeting. So the 52-year-old male, he was obviously very active before, and when I first saw him, he was 42 years of age, and he had difficulties with activities of daily living, and he had failed conservative treatment. And there's no ways at 42 I was going to do a shoulder replacement. And somebody who wants to continue mountain biking, you can see his range of motion wasn't too bad, but he had significant pain. And once again, another really bad outcome measure is for overweight people or increased BMI. They do worse. Your shoulder replacements are worse. So there's a group of patients who do badly: young males, overweight patients, patients with multiple comorbidities, and patients who are depressed. They have worse outcomes. So if you look at this as one of the grading of osteoarthritis, you probably should know for your exams, the Kellgren-Lawrence grading. So you had grade 2 on the left and grade 3 on the right. You can see he's got joint space narrowing, and on the right, he's got the osteophytes and less than 2 millimeter joint space. So Millett said that if you've got more than a centimeter of an osteophyte and if you've got less than 2 millimeters, you have worse outcomes. So that was when I saw him. And this was his first CAM procedure. You can see he's got a significant cartilage loss on his humeral head and posterior glenoid wear and cartilage loss. And he's posteriorly subluxed, as you can see on this view. So we routinely do a bicep tenodesis. So the CAM procedure is essentially a removal of the osteophytes, a capsulotomy, a bicep tenodesis, a debridement of the rotator cuff, an acromioplasty, and an AC joint excision. And that's what the comprehensive arthroscopic management means. So in fact, that shoulder did really well. So we did his right shoulder in 2015 because he had such a good result. So that was 3 years later. And there we can see, this is a view from posterior. The burr is through a posterior inferior portal, and we're removing the inferior osteophyte. So you can see on this video, this is the shaft coming down here, and this is the osteophyte being removed. There's the shaft, there's some of the anterior osteophyte, and we leave the capsule intact because you want to preserve the axillary nerve. And then at the end, then we remove the capsule. If you look at Millett's work, what he does is when he does an MRI, and if your MRI shows fatty changes in the teres minor, it means the axillary nerve probably being impinged upon by the osteophyte, and he says you must really try and remove it, and he does a neurolysis of the axillary nerve in the pouch. So I don't routinely find it unless I consider that they do have this posterior fatty changes in the teres minor. You can see he's got big loose bodies, and you can see his posterior glenoid wear is much worse than on the left side. Here you can see half the glenoid is worn away, and he's already got a B2. You can see there's a B2 glenoid, and he really has no articular surface on his humeral head. There's his loose body and his posterior subluxation. So in 2021, I saw him again, and now his right shoulder, which we did in 2015 over the last year, deteriorated and it had become much worse. And you can see his left side is still doing well with some mild pain. So that's a 10-year, nearly a 10-year follow-up of his left shoulder, but his right, which was worse to begin with, has now progressed. You can see the head is collapsing. He's got more osteophytes. They've recurred. And if you look at his x-rays, he doesn't look like he's got much posterior wear, but this is a CT scan. We can see he's got 20 degrees of retroversion. So an anatomical shoulder replacement is a really poor option. A reverse shoulder replacement, somebody wants to go mountain biking, I don't think is an option, is an ideal option at the moment, despite some of the reports coming out. So we've got a couple of options left, as we've heard from Kim. We can do a Riemann run and put a hemi-arthroplasty. This may be supported by the pyrocarbon. So maybe we should have put a hemi-arthroplasty or a pyrocarbon. If we look at a CT scan, and this really helps us now, this has sort of changed a lot of our planning and understanding of shoulder replacement. Is this statistical shape modeling of scapula, and then you can actually plan your procedure. And here we can see he's got 5 degrees of superior inclination, which is bad for a reverse shoulder replacement. It's probably even worse for an anatomical if you've got superior inclination, because you increase your tension on supraspinators and you get cup failure. And if you remember, anatomic shoulder replacements over time are more at risk of rotator cup failure. Plus, he's got 20 degrees of retroversion. So what we do is we put this in the system, and we can see what actually happened to the glenoid, how much bone we can move, where we position the implant, and what's good for it. Here we can see with 100% seating of the graft, we corrected to 10 degrees of retroversion. We've got no degrees of inferior inclination, and we downsize the glenoid so we have a very good covering. I think is one of the mistakes, that if you've got any overhang, this increases your loosening of the glenoid, and you don't want to expose your cancellous bone too much. So we felt that he was young enough that we would try an augmented glenoid, which has become more popular. So if we look at this review, 2020, 68 glenoids, follow-up of 50 months, so just over 4 years, only 2 revisions. All have remained centered. So this is quite, everybody seems to be making these augmented glenoids for this difficult problem of the B1 and B2 glenoids. This other follow-up also from 2020 with a 4-year follow-up as well, 49 shoulders. 45, they managed to correct the version with they had no revision, but you can see they had a porous metal wedge augments to address the glenoid. And we've got to be careful. This is out of Australia, because we don't know the long-term results of these porous metal wedge, even those without augments. In this other paper, I think this was in 2021, showed 92 patients, and they looked at CT scan pegging at a minimum of 2 years. And they were seeing some loosening, and they recommended for the B2, but not the B3 glenoids. So for your exams, you need to know the difference between them, and if you do shoulders, you certainly need to know about it. In this review paper of anatomic shoulder replacements with the B2 glenoids, if you do asymmetric reamings, you have a higher revision rate. If you put bone graft, you have higher revision rates, and the augmented glenoid had no revision rate. But you can see from the other ones before, that's not true. But you must remember, this was 2018, so they're probably 2-year results. But asymmetric reaming didn't seem to be an option. I can actually cheat a little bit, because there is a very big paper by the guy who's popularized it. It's out of Seattle. His name's Madsen, and they do a lot of Riemann run. In fact, he was the guy who popularized it. You can go and read the article. They have some really good results. We tried some Riemann runs, and long time ago, 10, 15 years ago, and weren't particularly impressed. I've also tried some of those biological autografts. I've used a meniscus, I've used capsule, and I've used Achilles tendon. And I think they've all ended up with revisions. But you must remember, we put those in a young patient, usually a post-traumatic and stiff, and they're the worst patients to operate on. So I'm not sure anything really works with them. So that's from the review paper. So here's his augmented glenoid. You can see from his auxiliary view, we've corrected his version. He's still got a lateralized head, because you can see his tuberosity is overhanging there, and we've got an inferior tilt on him. He's over a year now, and he seems to be doing okay, but we'll see in the next 5 to 10 years. The problem is, if we need to revise him, and we don't have a custom procedure to change him, what do we revise him to? We can take the glenoid if it comes out loose and leave him as a hemi, or now we're going to do a reverse shoulder replacement with increased bone loss from reaming him and correcting his version. Here's another bilateral cam procedure in a 56-year-old, once again, young patient. He had many years of shoulder pain. He'd failed conservative treatment, and he'd been offered shoulder replacement. In fact, a reverse shoulder replacement, because here you can see he has glenoid medialization. And when you see this double ring sign here, this is retroversion of the glenoid. In fact, you can see it on this. Can you see the lateral? Here you can see he's got gross posterior subluxation. If we CT him, on his right side, he has a B2 glenoid with more than 80% subluxation posteriorly. So he can't have an anatomic, really, even I think an augmented one. Here also more than 80%, and this is a B3 glenoid. So augmented glenoid, not ideal. So we could still put a hemi in here. We could do a ream and run, the pyrocarbon. But I discussed with him, if you look at Millet's work, he shouldn't have a cam procedure because he's got more than 2 millimeters bone loss, he's got posterior wear, and so not ideal. And those were scans back in 50. So if you look at them, that's when he's 4 years prior to seeing me. So he's deteriorated even more since we decided. So 2019, he underwent a right cam procedure with excellent pain relief. And if you look, his joints completely buggered. Can you see the massive synovitis, loose bodies, most of his glenoids worn away? There's the B2 part, and the humerus is gone. There's a chondrocalcinosis, synovitis, and look at his biceps. So his biceps here is being tenudized as well. And now, and when I did this talk here in 2001, he'd come back for his left side to be done because he had such good pain relief from the right side, despite his severity of disease. And this is his follow-up at 1 week post-surgery on the right. Look at his, on the left, this is his right side. That's more than 2 years. He's stiff, but he has no pain. And but you can still see his posterior sublux. Look how there's no fullness in the front there. And we've just done there, I've just changed the sutures, and there's his cam procedure, and he's actually already getting to 90 degrees and moving his arm. So I saw him at 6 months is good. And on the right, here's a mountain climber who's refused to have an arthroplasty. It's pretty difficult to see which side we've done, but if you look on experimentation, she's still a bit limited on the right. And she is now more than 3 years post, and she sends me pictures of her hanging off cliffs with the one arm. So she's done really well. So for the young patient, you must consider a cam procedure. You do warn them, though, there are failure rates and they can still do an operation. So what about the patients? Here's a different patient. He's now 62, a bit year older, but he's very fit and active, and he paddles in the sea, and he wants to continue doing it. And if you heard from Yapi, you don't want to be putting your shoulder to extremes. So we got to decide, especially with the reverse, and you're more chance of a dislocation with the reverse. So we looked at him. He had an intact cuff. His pain is now waking him at night. He's unable to do his exercises, and he's actually got a limited range. You can see here with severe pain. If we look at him, he's medialized. Look at his tuberosity is in the line with his acromion. So we do a CT scan, and what do we see? He's got 10 degrees of, by correcting him, if you look at the original glenoid retroversion, 19 degrees, and inclination superior 6 degrees. So once again, we plan. He wants to go back to sport, and now we asymmetrically ream. So we're going to take off more of the front, and we can correct him to 10 degrees. We've got good seating, no cancellous bone exposed, 0 degrees internal rotation. Are we doing the right thing for him? This is anatomic shoulder replacement in this this article, which was August 2019, is technically easier, and you must assess subchondral bone. So if you're exposing the subchondral bone too much, then you're going to get more glenoid losing. So they suggest that they shouldn't be doing it. So 29 glenoids, they did no correction of the version. So these are the patients with more than 16 degrees. They put a they put a normal anatomical shoulder replacement, which is against what Jill Walsh was saying, 4.5-year follow-up, 2 revisions. So in fact, that's probably about 6% revision rate over 4 years, which is probably not too bad. This next paper, this is by Frederick Matson, where they did no correction of version. Remember, he did a lot of he was doing the Riemann runs. So they did 66 shoulders with 62 B2 and B3. They did not correct the version. Following 2.8 years, no revisions. Published in 2020. So everybody's trying different types of options for them. So we could do an anatomical shoulder, and this is his glenoid, which can you see we've reamed it flat. It's fitting inside the glenoid, so we've got no overhang. Here you can sit it in very nicely. It's well seated, so hopefully there's going to be no loosening and no overhang. This is his post-op x-ray. Look, we've lateralized him a little bit. We've got his correct head size, and now we've got an inferior tilt, and we've corrected his retroversion. And here we go, 6 degrees of retroversion, and we've got inferior tilt. So we've corrected all the pathologies in the glenoid that probably will make the glenoid loosening. If we go back to his CT scan preoperatively, let me just see if I can find that. Let's go back here. So if we look, we can seat the glenoid quite comfortably in the glenoid without it protruding or becoming loose, and that's a trick, and we're not exposing the glenoid bone loss. So if you're going to do this, then you need to try and use the criteria for an anatomic. Also, if you look, he does not have 80% of posterior glenohumeral head subluxation, which I think is a contraindication. So let's go back. There's his results. So if you've got a B2 glenoid, there are many options available, and the decision-making is definitely patient-centered, as we discussed for each one of those. The age is very important, but probably more important than age is actually what activities they want to do. If you want to partake in high-level activities, I'm not sure a reverse shoulder is the answer. A total shoulder, maybe. Hemiarthroplasty is probably the better option, but they, as we heard earlier, they don't do as well. So John Sperling, who looked at all the youngsters out of the Mayo Clinic, he says 70% get 70% pain relief compared to 90% getting 90% pain relief if you do a total shoulder compared to a hemiarthroplasty. So you warn your patient, those are the outcomes. If you look at the Australian Joint Registry and many other units that put hemiarthroplasties in, they actually tell the patients they're going to be painful for a long time, 9 months to 18 months, and then they settle down. And if you look over a 5 to 10 year period, once they get past that painful period, they seem to have less revision rates. In fact, they don't seem to. They definitely have less revision rates than anatomic. You've just got to get through that first 18 months to 2 years. A CAM is certainly a good option for your younger patients. It doesn't always work, but there's some good results. And even a 50-50, I mean, you're saving 50% of your patients from having a shoulder replacement for 5 to 10 years, and then you can definitely change your different operations. If you're going to use a total shoulder replacement, the preoperative planning tools are very important when you're looking at version and bone loss to present bone loss that's present and remaining bone graft after you've reamed them. Okay, so that was just to go through some of them. There's many other things that are worth discussing, whether it's the stemness, so you're preserving bone on the humeral side, the glenoid design needs to be changed, and we can discuss pegs, no pegs, porous coating, and metal backed. Okay, so an hour and a quarter, all done. Any questions?